Hi, this is Brian Kim. I want to share with you case number 95 in the best way to do cataract surgery series. This is a patient with a soft cataract, and you're going to see double chop, cross chop mechanical fracturing of this soft lens. And this patient also needs a Toric IOL positioned at axis 165. And you're going to see how I'm going to use the INA tip, inflating the capsular bag with continuous irrigation, as well as using a Maltzman to position this lens exactly where it needs to be at 165-degree axis. I'm using a cotton tip to straighten the eye and using a corneal marker, which will help me to center incise orexis. I'm making my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane so I can get a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some dispersive viscoelastic to fill the anterior chamber. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then using the cannula to control the eye, I bring it towards me, and then I enter. This is a triplanar corneal incision. I inject some more viscoelastic to flatten out the anterior capsule. This is my rhexis forceps. This is the puncture style technique. I puncture the central capsule, pull down towards me. It didn't quite go towards me, so I'm basically with the teeth closed, encouraging the tear to come towards me, grabbing the right side of the tear, and then creating a flap going around circumferentially. Again, I'm using the corneal mark that I made, which will hopefully help me to center incise orexis. Burp some viscoelastic out, and this is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice fluid wave, decompress on the left side, and with the tip pointing down, I try to spin the lens. The lens is soft, and so it didn't really want to turn that way, so I'm pushing on the other side, and then try to make another wave. The lens didn't spin very well, but I go ahead and start the phaco, go in, lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Place the phaco tip under the rhexis edge contra-incisionally, pointing the phaco tip vertically sub-incisionally, crushing the lens and bisecting it in half, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip and bisecting the right heminucleus. Using a little bit of vacuum, I grasp that first quadrant, crushing the lens between the chopper and the phaco tip. Placing the chopper around the second quadrant, lifting it up out of the bag, using a little vacuum to position it, and then crushing it, and then emulsifying the lens piece. As you can see with mechanical fracturing, soft lenses are very easy to disassemble. Turn the second heminucleus in front of me, placing the chopper around the lens, crushing it against the phaco tip, and then emulsifying that third quadrant. Using some vacuum to lift that fourth quadrant up, crushing it between the instruments into smaller pieces, and then emulsifying the lens piece. So that's the endonucleus. That one piece was trying to escape me. I like to make sure I get every single piece before I proceed with the next step. So now I'm going to remove the epinuclear material, but because the lens didn't spin, I'm reluctant to grasp the epinucleus. If it hasn't spun, that means the epinucleus can be adherent to the capsule. And therefore I stop, I take the chopper out, push BSS in, take the phaco tip out, and I switch to the INA here. And so that's my biggest pearl in that situation. If a lens doesn't spin, that means the epinucleus is still adherent to the posterior capsule. If you go in with the phaco tip and try to remove the epinucleus with high vacuum, it can cause you to grab the posterior capsule. And I have done this before. And so rather go ahead and come out and go with the INA, especially with this polymer tip. It's very, very safe. But as you can see here, it's very adherent to the posterior capsule with the INA handpiece. I'm just taking my time, making sure I go very slowly and removing just the epinuclear material. You can see there's fine lens material still adherent to the bag. I switch to polish mode, polish under the rhexis edge, and I'll have to be mindful of the very fine lens material that might still be adherent within the capsular fornix and on the posterior capsule. And as typical with these cases, this patient clearly has some zonular laxity, which is another reason why these don't tend to spin as well. They're all kind of related. And so when I have trouble spinning the lens, I'll usually go and start to polish the capsule, and I can see that the posterior capsule is really, really diaphanous, and there's not much counter traction within the fornix. As I'm trying to polish, you can see how easily the posterior capsule puckers into the INA port here. So I'm working on a subincisional posterior capsule here now. Go ahead and use a cannula to pulse the subincisional capsule fornix. You can see there's some fine lens material there. Try to pulse it, and then I grab it with the INA tip. Still some fine material in the subincisional space. Because there's not a lot of counter traction, it's a little bit more tedious trying to peel this stuff off. So I decide to fill the capsular bag with cohesive viscoelastic, and then I'll use a sweep to go after that subincisional material. And as I do this, it starts to come out quite nicely here. Again, you could use bimanual techniques. Because I'm used to doing it coaxially, this is kind of my preferred way of dealing with the subincisional cortical material. So I'm polishing on the right side now. So it looks like that subincisional area is clean. So this is a single piece acrylic toric lens. It's taking a little bit of effort to get in. Again, that's because of the smaller incision size. I like to get the entire barrel into the eye if I can. Because a lot of viscoelastic came out with that maneuver, I pushed some more viscoelastic to fill the bag. I advance the lens into the bag. You don't ever inject the lens into a bag that's collapsed. I go in with irrigation off, activate irrigation, make sure both haptics are in the bag, go under the optic, tilting it, rotating it 90 degrees, removing all the viscoelastic from within the bag, repositing the lens, switching to polish mode, making sure I get all that material from between the lens and the posterior capsule, polishing under the rhexis edge. And like I said, in these cases, there's oftentimes this fine wispy material when you're not able to achieve a really good mobile lens here. So I go to low mag, and this will help me with my alignment. Again, it has to be 165 degrees. And so I have a long ways to go here. I have about another 90 degrees of clockwise rotation to go. So I have the Maltzman now, and with the INA and the Maltzman, this is a key. You have to have active fluid, so continuous irrigation, which will inflate the capsular bag. And so there's very little risk that you'll manipulate or hurt the posterior capsule. So by the bag being inflated, you can confidently reposition the lens in the direction you want it. Again, in this case, 165 degrees. I go to low mag, which does give me a little bit easier view of my orientation for the axis. So again, I use both the INA tip as well as a Maltzman. And here in the final steps, just using the INA tip to tease it towards the 165 degree axis. And once it's in place, I push BSS in, take the INA handpiece out, making sure the chamber doesn't collapse too much. And this locks into position, and then I hydrate my incisions. So again, this is a patient who had a soft lens. I performed double chop, cross chop mechanical fracturing techniques. Again, with the soft lens, mechanical fracturing is really the most efficient way of disassembling the lens. You can just directly crush the lens in half rather than worrying about lollipopping it and it breaking apart, sculpting it and breaking apart. Just directly attacking the lens by crushing it with the mechanical fracturing forces is really a very easy, efficient, and elegant way of disassembling the soft lens. You saw by inflating the capsular bag under continuous irrigation, I'm able to manipulate the lens to the 165 degree axis. And I use the INA tip as well as the Maltzman to very carefully orient the lens. I go to low mag to make sure I'm aligned. I push BSS when I come out to make sure the eye doesn't collapse too much, and I hydrate the incisions. This is the final check, and I look and see, and it's exactly where it needs to be, 165 degrees. I check my incisions, and that's the end of the case. So again, this is how I handle a soft lens and rotate and control the Toric IOL to get it into the proper location. So I hope this was helpful to you, and I thank you for your attention.